Hello, hello, hello. Boy, I miss doing that, Roger. You have no idea how much I like doing that.
You're a strange guy, Bob.
That's why you let me do this, because you need to bring the strange. So
You get
we're here with another benefit roast. We are going to leave planet Earth today, and our command center, our control center, the guy who's going to steer the ship is Rodger Bayne, who, for those of you who don't know, Rodger is one of the preeminent forces when it comes to understanding health insurance, its implications, how to sell it, and how to do self-funding. And I don't say that lightly. I've met hundreds of people in the industry over the years, and Rodger is really the one that I go to with all of my questions. And today he's going to talk through the new Benefit Indemnity Corporation Galaxy plan. Now, as he's doing this, you have an opportunity to get involved in the discussion. You can go down into the little chat box, ask your questions, give us a statement, say, wow, that's amazing. I can't believe it's possible. Tell us how close you are to another galaxy, whatever you choose to do in that space. We're happy with that. So that's there for you. It's right to the right where it says chat. Just type away, and we will read those as quickly as we get them in. And with that, Rodger, I'm excited. Tell us about this new Galaxy plan.
Well, the Galaxy plan was released just, I don't know, 6 weeks ago, Bob. It's not that far out in the world yet, but it was developed kind of as a hybrid from my Maryland plan that we built. And the Galaxy plan has more national capabilities, and so we haven't talked enough about it yet. So I think that's why we're here today, to really talk to people about what we're doing. We're taking, I think, probably the largest step toward integration of a healthcare delivery system and a health benefit plan since the advent of the HMO. We're going further than a patient-centered medical home. We're going further than, better than what an HMO did, because we're looking not at quality, not at just cost and who's our doctor, but the quality of the doctors and the quality of the provisions and the delivery of the care as well. So there's just some really great strides we're making to really take a health plan and make it an instrument of healthcare in a way that drives better cost and benefits for everybody.
Okay, wow, that's ambitious, to say the least. So break it down for us more. I know it on the surface, it looks a little complicated, but you found some ways to simplify it, right?
Well, you know, it can look complicated in one way, and another way it really doesn't. I mean, the best thing you could say is pick up the phone, call your medical concierge, your patient advocate, call the nurse, whatever you want to say. Just when you need care outside of a routine office visit, you pick up the phone, you call, and you get true medical advice and guidance. Most health plans today give you a big PPO book. It's empty as far as quality measures, as far as real direction, as far as understanding your symptoms. It's just a dart book. So instead of having a dartboard book, we're talking about truly driving quality care through quality providers and helping the patient truly understand what their circumstance is and what the best treatment for them is. And finding that best treatment isn't just something made up by a nurse at the end of an 800 line, but it's made up by data collection and clinical evidence of millions and millions of data sets compiled across the country and across the world that help us drive today's modern evidence-based medicine.
So you bring up evidence-based medicine. Explain what evidence-based medicine is, if you will.
Well, it's real simple. I'm going to throw the slide on the screen because it's tough for people to remember all of it. But bottom line is, it is the most conscientious and reasonable use of modern evidence in making decisions about the care of individual patients. So we're talking about clinical experience and patient values with the best available research information available. So not just a clinician's anecdotal knowledge, right? There's an article that I cite later today that I'll give to everybody that will show like a pyramid in that article of where you get the best direction. And the base of that pyramid is a provider's anecdotal knowledge and experience. And then as you get further and further up, you're talking about true data of clinical sets from trials and evidence-based results that really help us understand what the best care is. So evidence-based medicine combines all of this data capability that has come into the world today to use that data and apply it to get the very best scientific evidence that you can to go out and get the results. So that clinical research goes right hand in hand. And forgive me if I sound like Dr. Fauci, who doesn't sound like he really has a great idea, but for the rest of medicine, there are millions of patients that have encountered certain symptoms from certain situations, from certain environments, at certain demographics, and we can interpolate from the use of that data what the best results, outcome, and treatment really are in today's world. So if we don't use that, then we're just taking anecdotal evidence from a physician, which isn't always as comprehensive as it would like to be. I was reading an article the other day that talks about a physician, and I think all the brokers on the line here today can relate to this. For a physician to keep up with evidence-based medicine practical guidelines, the experts suggest that they will need to read 19 medical journal articles every day. And of course, interpolate those and understand them and be able to retain those.
That's
now,
heavy reading.
That's heavy reading. And
that's not a John Grisham read it at the beach kind of thing.
Right, and that same article cites that most physicians have about an hour a day allotted to that type of reading. There's no conceivable way they can do it, and they're not computers. They can't keep up with the amount of data and understanding and knowledge that's out there. So what we're saying when we look at this is we're saying, let's give those providers those tools. I mean, they're out there, but not all providers have them. Not all providers know how to use them. We can help them with that radically and put that evidence-based medicine right at their fingertips. So above all, we're saying that we're going to make sure that we get the optimal diagnosis or therapeutic procedure from scientific evidence, from research, and really get that in the hands of the patient in a way that they can get and have confidence that the care that they're getting delivered to them is the appropriate care in the appropriate setting, in the appropriate way.
So essentially, you're doing what we've always assumed, but we know really isn't possible. Bringing the best medicine to each individual case, which I think we've always believed was something our doctors did, but the volume of the information that they would have to identify, find, and then process and interpret, and then be able to apply to a situation is just too overwhelming. So rather than expect them to do it, you're saying, here's the doctor with what he says. We're going to put the second piece of the puzzle together, which is the evidence, the scientific data to support a medical decision or not to go forward. Do I understand that?
Well, yeah, that's right. And think about it, Bob. You know, we grew up thinking the family doctor was the very best source, right? He's got the most universal understanding and application. He knows more about you than any specialist or hospital or clinic. So your family doctor was the guy. And 60 years ago, that was probably very, very true because all of the right reasons. And the data set of information was so much smaller then that was our best choice. Now that the data set has grown to be millions and upon millions of pieces of data and outcome studies, we now need the systems, the science, the data, and the systems to analyze that data and give us results and establish, therefore, those guidelines that will combine, like you see in this chart, patient values and preferences, who they are, what their family's like, what they need, what they can and can't do, what they're going to fathom as the appropriate level of care and what they're not. All of the best evidence that goes on from all of the data collection of what we do in the world of medicine, and then, of course, clinical expertise. And that clinical expertise is another big component delivered by the physician. Now, when you combine those three and you pull them all together, you see that little section, that triangular section in the middle, that is the blend of all of those elements, which is what evidence-based medicine is all about. It's seeking the very best in outcomes by combining clinical expertise along with evidence and patient values and preferences. So that's the really big story in a nutshell right here in this diagram.
So the benefit within a self-funded plan of this evidence-based medical approach is that outcomes are better, which over the long haul means that costs will be lower. Fewer readmissions, fewer complications, fewer mistakes, fewer misdiagnoses. Is that what this really gets at from a why would I care as an employer perspective?
Well, why you would care as an employer is completely agnostic to what type of health plan you have. Whether it's fully insured or self-funded, any employer should be thrilled to be able to introduce evidence-based medicine to every encounter that his employees have with the healthcare system. And that's because better quality yields better results, yields better patients, better outcomes, better employees, back to work faster, healthier in general, and overall saves money as well. Quality care costs less, right? So the reality is when you look at this, whether you're self-funded or not, this would be a great model. The advantage to self-funding is I can build this model on that platform and go make it happen. Where in the fully insured world, it's just so much more regulation and complexity in order to get to that.
Okay. Now, if I'm a patient, part of what scares me or could scare me about this is I have a cardiologist that I adore. What happens in the case that he says you need to have a stent put in, but the evidence-based medicine suggests something else? How does that get refereed? Because I don't want to upset my doctor. He's been with me for like 20 years. We're buds.
Well, the reality is in that scenario, that's when your physician should be perfectly willing and ready to look at what the evidence says and what the alternatives are and what the results have been on his recommended practice. You know, physicians pretty much know that they don't know everything, or at least we hope they do, right? And so if you have a physician that has a disagreement, then we have to look at the root of that disagreement. And I will be honest with you, sometimes the root of that disagreement is about the doctor getting paid more money. And that's a real shame, Bob, but we have seen experiences where the physician says, no, I know you have a clinical trial, and I know you have 400 patients in that clinical trial, and they're all being studied and examined, and they're all being treated for the same condition in this clinical trial, and they're all being treated for free, but I want to keep my patient because he yields $120,000 to my practice. True story. So when you look at that kind of thing, you have to remember that you have to look first at the source of the disagreement. Is the physician embracing evidence-based medicine and the data and the outcome studies and the history and just simply disagreeing? Or is he rebelling against it entirely? Or when enlightened, does he agree and say, you know, that looks like that is the best method, let's go forward? But when there are differences, it is always best to work those differences out. Let's find out what the basis on the difference is and let's get it solved. So for example, Bob, you've gone to your cardiologist, he says you need a stent. All of the evidence in the data says absolutely not. A stent for you is higher risk, and the results show 30% mortality, where doing nothing or doing something else shows 95% success. What do you want to do, Bob?
Of course, I want to do the opposite, but, well, I'll leave it there. I do think within the medical community, it can be somewhat complicated. And in that case, am I talking to my doctor about this evidence-based medicine, or is the person in your Galaxy plan having that discussion?
Now, you would likely let the care manager, which is going to start at a nurse clinician level and move right up to a medical director, so that you allow your physician to speak to his peers.
Okay.
And have a peer-to-peer discussion about what the best avenue of care is. I mean, we're not talking, Hillary Clinton made fun years ago when she was creating her version of a health reform plan, I guess back in the mid 90s. And she made fun of a physician being told what to do by a 22-year-old registered nurse in Ohio on the end of an 800 number. And that stuck with a lot of the American population, and they are fearful that insurance companies and other entities that have this advice are really looking purely to save money. And what I'm suggesting to you here is that we're getting way beyond that. And now we're talking about our own evidence shows that quality care costs less. So it's in our interest as a health plan or as a health insurance broker to deliver quality care, because that keeps everybody happier and costs less and keeps people healthier. So yes, you're always going to see resistance to change, but this is a relatively common and well accepted mode of operation in the medical field today. The terminology of evidence-based medicine should not be foreign to any physician that you're seeing. And if it is, take that as your warning.
Okay. And
Okay.
there's no additional cost within the Galaxy plan for this service of figuring out the right fit and all that stuff, correct?
No, and we'll show you kind of how that works. The reality is the beauty of the Galaxy plan is the layer upon layer upon layer of improved quality and cost is actually intended to drive the price of the plan down, not up. So what we're doing is using everything we can to get the very best price up front. And we'll talk about that a little bit later.
Okay.
So from an article I found kind of describing this, written by a physician, talks about the 5 reasons to get into evidence-based medicine. Number 1 is it helps the clinician stay current on the standardized evidence-based protocols. It uses near real-time data to make those care decisions. We improve transparency, accountability, and value. We improve the quality of care and thereby improving the outcomes. So Dr. John Haugham from Health Catalyst wrote the article, 5 Reasons the Practice of Evidence-Based Medicine is a Hot Topic. And when you continue to look at that, the article continues to say that clinicians must practice evidence-based medicine because there is an ever-increasing need to have access to that evidence. And so that's what's really important. And there's a link to the article. I think anybody that's interested in delivering the best care to their population should ask questions about their health plan, and is their health plan engaging in any of these types of things? If you think about it, some of the insurance company initiatives are really trying to move in that direction, right? They create things like an HMO or the patient-centered medical home, and in that thing they try and get a physician to drive certain proper or best case practices. And a best case practice is almost another way of saying evidence-based medicine, right? Because what we're looking at is what's the best case result been for this type of condition over the years of data collection, what makes the most sense. So we're always driving to get the best care in the hands of the member, and that's what we really need to do. So when we say that, we move on to say, why is Galaxy out of this world? Well, because the Galaxy plan is the only plan I know that is fully moving toward fully engaged evidence-based medicine. We're talking about driving all the way through into a health plan, fully engaging the practice of evidence-based medicine with patient advocacy that supports directing to the evidence-based medicine for those very best outcomes. 24/7 customer service and patient advocacy, so you can reach out anytime you really need care and get that direction. And we've integrated it in with the health plan and with the health plan benefits to give everybody the very best exercise of that practice. And the advantages of that practice accrue all the way back to the employee level. So not only does the employer save money, but the employee gets better quality care and for less. And you can't really beat that very easily.
Hey, Rodger, let's get our audience involved in this. I hate to think they're not having some fun. If you want to learn more about the Galaxy plan, you want Rodger to dig deeper into it, put a Y in the chat box. Go ahead, let's get some Y's in there. There's always a lag, don't worry. And if you have a question, feel free to share that with us. I see a hand raised, Rodger. I think I see a question mark next to someone.
If somebody put the Y in the question box.
There you go. Great. Thanks. Thanks, Trudy. Appreciate that. All right, Rodger, there you go. You got a Y. Let's keep going. Let's talk. Let's talk out that gallery. There we go. We got 2 Ys.
We got a few more trickling in. So let's
keep a lag time.
Right. Let's keep talking about Galaxy being out of this world and why. And let's talk about one of the very grassroots pieces, and that's a benefits app. Benefits app is an application you download to your phone. You have the power of your health plan in the palm of your hand at any given moment. And the value there is that you've got a 24/7 call center, for, not only for customer service, but for patient advocacy. They can direct you to call the nurse or to call telemedicine, or maybe both, depending on your need. And when you get referred there to telemedicine, that means you got a 24-hour physician. So not only just telemedicine, but integrated telemedicine with the mobile app and the managed care and pre-certification firm. Many health plans today offer a nurse health line or a telemedicine option. And so many times we see that they don't share the data. So our managed care firm that helps manage this group is going to be using full integration with their telemedicine, so that the nurse clinicians and the medical director are going to know that you called the telemedicine doctor the night before or the afternoon prior. They're going to get that information every single morning. So they're going to know when there's encounters with telemedicine, there may be needs for intervention and help and direct better quality care. So the fact that we link all these in and tie them together with full integration from the benefits app to the telemedicine to your medical manager is something that is really a strong advocate for the patient.
Hey, Rodger, I'm going to jump in because Alan Schulman just said the Galaxy Diamond plan just saved a group in Pennsylvania over $75,000 on cancer treatment. That's serious coin.
There's I think the number was actually maybe a little higher than that, but yeah, there's some great case studies that are developing every day. And Alan, thank you so much for that, because that's a really good point. This person moved to a new facility, and the outgoing facility that was losing the patient said, "Oh, that's a really good place. I'm sure she'll be happy there." So, you know, these things are always sensitive and always challenging. You know, cancer treatment isn't fun, but that doesn't mean that every cancer treatment is the same and has the same guidelines and intent on what they're doing from a perspective of cost. So there's a lot of things there. So now what we're doing is we're combining the managed care, the case management, and the pre-certification company, and they're following evidence-based medicine care guidelines. They're integrating that completely with telemedicine, a benefits app, claims and customer service, and then they're doing predictive modeling with all the claims data they get on our entire block of business every month, so that now we're looking at saying, okay, not only do we know what the evidence is for people that are encountering the medical services, but we also know what we're expecting from people that have encountered the medical service and they don't even know that we can predict that they're going to have additional encounters that we can help them with. And so when you start adding that and managing the cost of prescriptions that are offered in hospital or facility settings, case management on any of your large claims, negotiating direct payment and bundled care options, even with the authority to waive your copay in order to make a physician or a provider happy with a reimbursement level, saving the employee, again, more money, and the health plan. That's all about tying all of that together. And then we go a step further and we layer the transparent pharmaceutical benefit manager that has their own clinical management on the prescription drugs. They have pass-through pricing with the rope note without any markups. They don't receive any rebates. They provide full clinical management and outreach. They've just improved their coupon program so they can reach out, capture coupons that help the employees on expensive drugs sometimes to save on the copays for those. So we can save copays for the employee, get the drugs less expensive. We're doing a couple of other new programs there, but they also can direct to alternate sourcing when they find a medical expense or a prescription drug expense that can be attached there. And we can essentially get manufacturer's assistance programs for some of those prescriptions, getting them nearly free, or we can get international mail order, or we can refer them to prescription drug tourism. And all of those things go hand in hand and fully integrated with what we're doing across the board in following this evidence-based medicine track to get the very best clinical quality care and the best results. You add to that the TPA services that we've selected that really have account management second to none. I've been in this business 34 years. We've been working with this firm since 2013, and the work they do for us is absolutely tremendous. And they are fully integrated with all of the vendors, partners, and the product enhancements that we build. They're highly trained and they have licensed customer service people. So when you call there, usually when you call an insurance company, you get somebody for customer service, they look into your claim and they come back to you in 2 weeks. Well, the target here is to have first encounter closure of most claims questions. So that when you call, you're speaking to someone that's licensed, that knows, can look into the claim system and can fix it if something's gone wrong or explain it if something hasn't. So there's some really great strength there. Now let's talk about the infinite and dynamic provider selection that comes hand in hand with this. We can't recommend the very best provider if all we're doing is giving you a book and saying, go pick your specialist out of this book, go pick your hospital out of this book because they're a participating provider. You're going to have your medical concierge and your patient advocate that you can pick up the phone and call them for anything aside from a basic office visit. You call the nurse and you get your care direction. You're going to get recommendations not just to providers that are in a book. You're going to get recommendations to the best providers in your area for the type of care that you need. You can review with those providers, you can call them, you can schedule an appointment. If you don't like the demeanor of a particular provider or you're not happy with the list you had, you call the nurse again and say, look, I talked to these 3 folks, not really thrilled. Who else is nearby? They have minimum quality standards, have to be at least 94 out of 100 points on industry matrix quality standards. That's true result outcome studies for providers. We're not talking now about Yelp reviews and anecdotal information because this doctor was really nice or this doctor was really good looking or she was super good and attentive. We're talking about true outcome data and submission of results that are being studied by over 25 different industry matrices and companies that actually do these studies so that we can make sure that we're delivering care at the highest standard possible. That
Rodger, just to jump in, the ability to gather all that data is because of the changes in healthcare over the last 10 years or so, right? That it's all being tracked in a way it wasn't previously with access that anyone can really get if they know what they're doing?
I would say, Bob, that it's probably a little bit more than 10 years. It's more in the 15 range. Well before the ACA passed their PCORI fees, which is patient-centered outcome research, whatever. That was all about collecting data to do just this. But well before that, there were already companies collecting this data and using it for predictive modeling and helping to drive these things since the early 90s. So you'll see this work growing from all the way back then to driving the ability to deliver evidence-based medicine and these quality issues even before the ACA was passed. In fact, I don't know if you remember, but you may have heard me during the whole process of the ACA suggest anecdotally, why is the government forcing us now to pay for all of this data collection that's already being done by the private sector? Why don't they just reach out and cooperate with the private sector and use that data that already exists for tens of millions of encounters in the medical field? Well, so today we're just adding all of those things to this. You continually develop data, and you can continually develop the technology that can ascertain the results and what that data means. Now you're talking, we're at a point now where we should be using it completely.
Okay, that makes sense.
That help? So, yes, we still give you a PPO provider network for basic office visits and for outpatient care, but that basic PPO access for guided outpatient providers and ancillary services. And what that means is we want you to pick up the phone and call the nurse and make sure you're seeing the right PPO provider. Because many people don't realize this, but in a PPO book, you could be seeing a provider with no quality measure whatsoever. There's just no guidance on quality or results or outcome studies for that physician, but also nothing for price. They're just in the book, so I can use them. I can get my in-network benefits when I go to Dr. A or Dr. B or Dr. C. But for the same service, their quality may not be directly tied together or related to their price, and their prices could vary tenfold within the network, which is just absurd. You can go for a colonoscopy in the Baltimore metropolitan market for as low as $600 or $700 or as high as $7,000, and probably both of those facilities are inside a PPO network somewhere. So to think that you can just blindly go to a PPO book and get your best care for the best price it's a misnomer. So by using the right medical management firm, we're able to guide you through your PPO providers and ancillary services, and even negotiate if we find a physician outside the network that's going to do a better job. So then we get potentially greater discounts for lab, x-ray, imaging, diabetics, supplies, durable medical equipment, and more, because we're actually working to negotiate with these providers through the whole process. We can get surgical centers, ambulatory surgical centers, or outpatient facilities to do bundled surgery with quality requirements and better pricing and even accountability. So sometimes we get those at or near Medicare prices and for better quality and in a facility that's outside of the hospital and is much lower risk for all of the types of things that you go on today with secondary infections. So patient advocacy and a guided network care. In essence, what you're looking at is you're getting a network that is dynamic and infinite, because we're going to build the network around you when you need your care. The orthopedic surgeon you saw for your knee may not be the same guy that should be doing your shoulder years later. So you need to know that. You need to know the results. Just because he's a great orthopedic surgeon and he's the best knee guy in town, that doesn't mean he's the best knee shoulder guy in town. So all of that information has to come out through the work that's being done behind the scenes, and that's what we're doing. So we're using reference-based pricing for facilities so that we can negotiate and coordinate that care with the care manager and the clinical directives and make sure we're getting you in the right hospital for the right price. Transparent facility pricing is valuable to all of us, and fortunately, the president's executive order was just upheld in court a week or two ago. So hospitals are going to have to start disclosing their costs more, which is going to make this methodology easier and easier over time. And then, of course, you have much more consistent savings compared to less predictable PPO discounts. So you have access to the centers of excellence. In fact, Some procedures, we're going to say you're going to a center of excellence. That's how you're going to be covered. We're not going to do a kidney transplant in a hospital. It's not a center of excellence for that. And so we're going to make sure that we take the most critical and crucial care and get you in the most appropriate setting for that as well. So you get so many different advantages. And then the benefit of that is you have free or near free healthcare for following the evidence-based medical guidelines or the directed care provided by the Galaxy Plan care manager that you've been talking to every day. So the guided network care provides rich benefits. In our Diamond plan, for example, you have no copays whatsoever except for prescription drug. So all of your care, if you follow the guidelines of the evidence-based medical guidelines and the direction to the right quality providers, then you're going to have free healthcare. And that's a huge statement. And if you don't want to follow, you're just adamant, Bob, that your surgeon said you need a stent and this is what you need to do, then as long as it's medically necessary and it's covered service, you can still go do it. You can see anybody you want, and you're going to pay a deductible and coinsurance probably similar to your current plan. So,
Wow.
so that you get the best of both worlds. You get all of the incentives and encouragement to follow evidence-based medical guidelines and get care in the right place from the right providers and for the right price. Or if you insist that you know better than all of these organizations that we've teamed together to help you get the best care, if you know better, you can pay your deductible and coinsurance and go get better.
I see what you did there. That's pretty good.
Yeah. So quality of care is always the emphasis, right? This is what we're driving for. And we are just so lucky as a company that builds health plans. We're very fortunate because quality of care can be our emphasis, and that drives down costs. And frankly, that's what sells health plans. So we are just going to kind of close my discussion, and we'll open for questions for anybody that has them. But our team at Benefit Indemnity Corporation, and a number of the people out here on this call know that we have extensive experience in self-funded and building health plans in general. We do a free group risk assessment. We even bonus brokers for doing it. We do joint sales and enrollment meetings and webinars. We'll do full spectrum of support with the brokers from a prospect to installation and be right back again at renewal and throughout the year. And we create these innovative product designs like the Galaxy and the Maryland plans in ways that really help. Now, this, Bob, kind of goes to your question that you asked earlier. Aren't all these things expensive to add all this? Well, they are. There's a cost to building all of these things. But what we do at Benefit Indemnity Corporation, we vet these providers, we scrutinize them highly, we do the research, we do the study, and then we select the providers that we can go negotiate with the insurance carriers, the stop loss carriers, and say, hey, here's what we're doing. Here's how we're going to build the plan. These are the cost containment measures. These are the quality measures. These are the things. I need you to discount your premium now, because small employers don't typically buy health benefits hoping that they get claim savings down the road. They're looking to get the very best rate. So the fact that they need rates and they need a return on that investment in a large group, if you had 1,000 employees, you would do everything I just said in this presentation, and you would pay for those services, and you would know that you're going to get a return on investment from the claim savings that happens. In small employers, it's a little tougher to make that same kind of discussion. So we negotiate that return on investment by getting the very best rate for the health plan in the very beginning. And then if you have claim savings that comes back to you, which it does in all of our plans, then that's an added bonus.
And Rodger, how small a group are you working with?
Well, we work as small as 5. Our sweet spot is 15 and above, but we do have 5 to 14, and we're working on getting some of the administrative costs in there. The problem in the 5 to 14, Bob, is like you said, some of these things are expensive to build. So the smaller the group, it's a little bit harder to get that cost absorbed. So it's just slightly higher than we'd like at the moment, but it's still saleable, and we still sell groups there because it's not always higher, but sometimes it's not as competitive. But 15 and up, we can do some just great work. We're seeing extremely good rates. Alan suggested one. His group was over 100 employees and needed some really unique things. And we're seeing a lot of traction in these months, even coming out of this slow spring for the COVID ordeal. We're now starting to see really a lot of traction, a lot of tension and excitement about what we're doing in the Galaxy plans.
Okay, but do we have questions, folks? If you have questions, you can put them in the question box or in the chat box. We'd be happy to answer them. I know Rodger threw a lot at you. He tends to do that, but why don't you go back to that one slide, Rodger? I think it's slide 6. Just because once you see all this, I think this slide for me really crystallizes it. There it is. That you have that combination of patient values and preferences, best evidence, and clinical expertise. When those marry, that's evidence-based medicine.
And the reason I was talking about evidence-based medicine today is a lot of the folks on this call are repeat visitors, and they come hear us talk a lot. And when I talked about the Galaxy plan and kind of the early meetings and the teasers, and we were talking about some of the mechanics and the price. And I don't think we talk nearly enough about evidence-based medicine and the quality component. So that's why I kind of wanted to emphasize that today, because when you're out talking to your customer, you don't want to say or even make them feel that I'm getting a cheap price because you're telling me where I got to go. That's not what this is all about. This is all about evidence-based medicine driving you to the best quality of care, and that yields the lower price and the lower costs. That's what it's all about, and spinning that the other direction would be a total injustice. So I just want to make sure we're all on that page.
Right. I also, personally, I love the idea of having someone you can talk to that cares about where you are in the healthcare system and fits you where it makes the most sense, because most of us do not have medical degrees, and when you're going through a health crisis, the last thing you're doing is thinking about things rationally. So having that person that can separate and go, hey, I've done the research, I checked out your doctor, I checked out the facilities, the type of care you need, and this makes good sense for you, or have you considered this other option?
Yeah, Bob, the interesting thing that I'm finding is that as we roll this out and we get more and more traction and we're talking to more brokers and more companies, the companies are embracing this with a little bit of apprehension about how their employees are going to accept it. But when we get into an enrollment meeting, the employees love it. What we're realizing is that most of us in America, when we need medical care, we are instantaneously frightened. We have no direction, no knowledge, no idea. We need care, and we are blindly following some insurance company's directory of doctors and a referral from the doc that said I have this problem, and we're getting little to no information along the way. And it is scary, and we all would prefer to have direction and support. And so that's what the Galaxy plan is doing. It's delivering all of that on steroids to get you the very best quality of care.
Well, that's awesome, right?
And not that steroids are the best thing. I'm not saying that. I'm just using the expression.
That's a good clarification. Well, Rodger, I don't see any questions, so you've either mystified people or you've answered all their questions within your comments.
Well, I think a lot of their questions will come when they actually get into the practice and they want to really start looking at a group and they're going to quote it, and then we can kind of go through piece by piece. They all know that we are available.
And you have been quoting this, right, for a couple months, correct?
Oh, yes, we have. That's why I say we're getting some pretty good traction on it at this juncture. So
okay,
I lost my slide presentation here. Sorry, guys.
You're on questions. And there is, if you look in the chat, you've got a way that you can get a cup of coffee on Rodger and the fine folks at Benefit Indemnity Corporation. Just go to the chat and fill out that form, complete the form, complete it. Don't just throw your name, put everything they ask for, and you will get a lovely gift from Rodger and gang that will certainly brighten up your day and give you a little caffeine boost too, right, Rodger?
That's right. And if you guys, if you want to take a look at that article, you can ask for the copy of this. We'll send it out to you. It's got the link to the article on evidence-based medicine, which I found was a pretty good little summary of what you need to know in order to really get the best traction and discussion with your customers. Best thing I can do is tell you is talk to your customer about what's really going on in the quality of healthcare, and talk to them about their employees and when they had their last encounter with healthcare, and just what they felt they really needed. And what I think you'll find they really needed more was help and guidance and direction more than anything. And that value will become very, very high in the employee population, and will make your clients very happy.
Rodger, I think with that, we should close the book on this episode. We will be back in 2 weeks. I just looked, it'll be lovely August 10th. We'll be talking about the 3 biggest objections to considering self-funding for employers. So if you're trying to deal with providing self-funding, it'll give you a little insight into how you can overcome those objections. That'll be at 2 p.m. Eastern on Monday, August 10th. Until then, be well and go out and sell some Galaxy plans, because I hear they're out of this world.
Thanks, guys. Appreciate it.